Hi, everyone. Welcome to Question of the Week. My name is Faustine Ramirez, and I'm a master tutor with MedSchoolCoach for Step 1 and Step 2. And today we'll be reviewing a Step 2 CK question. So let's start by reading the stem. A 20-year-old woman presents to the emergency department with 1 day of abdominal pain, nausea, vomiting, and shortness of breath. She has been feeling under the weather for the past week with a cold. She has no significant past medical history and takes no medications. Prior to her cold, she had noticed that her appetite had increased, and she had been more thirsty than usual for the preceding 2 weeks. Family history is notable for hypothyroidism in her sister and Crohn's disease in her mother. On examination, she is afebrile, heart rate is 115, respiratory rate is 25, and blood pressure is 112/75. Her mucous membranes are dry. Capillary refill time is 2 to 3 seconds. Respirations are deep. She has mild abdominal tenderness to palpation. The remainder of the examination is unremarkable. Laboratory results are positive for urine and serum ketones, as well as blood glucose of 360, sodium of 134, potassium of 4.5, bicarbonate of 14, and chloride of 100. Venous blood gas shows a pH of 7.1. What is the next best step in management? So I'd like you to pause the video for a moment and try to work through this question on your own first. All right, so welcome back. So let's approach this question together. As always, the first step is going to be to read the actual question, so the very last sentence, to see what the question is asking us. So here they're asking, what is the next best step in management? So this is going to be a management question. And then we briefly glance at the answer choices, and we see that they all involve some combination of insulin plus some combination of fluids and something else in those fluids. So this is going to frame how we approach this question, because again, for these boards questions, we have to not only identify what the diagnosis is in the first step, but the second step is to actually answer a question about it. So as we're reading, we're going to be thinking, what is the diagnosis and what are we going to do about it? And we need to be thinking about what types of fluids we're going to use, what type of insulin we're going to use, and maybe what extra something we need to put in our fluids. So let's start by reading from the top, and we'll highlight the key elements. So a 20-year-old woman presents to the emergency department with 1 day of abdominal pain, nausea and vomiting, and shortness of breath. She has been feeling under the weather for the past week with a cold. She has no significant past medical history and takes no medications. Prior to her cold, she had noticed that her appetite had increased, and she had been more thirsty than usual for the preceding 2 weeks. So when we highlight elements, we're going to highlight the key findings from the presenting symptoms, so what the patient is complaining of, and we're going to focus on the more specific symptoms here. And then we're also going to highlight any past medical history or medications if the patient has any. Now she doesn't have any, so we can skip over that section. Then we read family history is notable for hypothyroidism in her sister and Crohn's disease in her mother. Often family history is very relevant. Now it could be there as a distractor, but often if they take the time to give us that information, it's that it might be useful. Although you want to be careful to not get too distracted because sometimes it is there as a red herring. On examination, she's afebrile, heart rate is 115 per minute, respiratory rate is 25 per minute, and blood pressure is 112/75. So the heart rate is elevated and the respiratory rate is elevated. So I recommend always highlighting abnormal vital signs because those are often pertinent positive findings for the underlying diagnosis or are going to be important when you're thinking about the next step in management. So always highlight abnormal vital signs and don't highlight the normal ones so that when you look back at the stem, your eye goes right away to those abnormal vital signs. Her mucous membranes are dry. Capillary refill time is 2 to 3 seconds. So the mucous membranes being dry and the slightly prolonged capillary refill time gives us a sense that she may have some mild dehydration. Respirations are deep. She has mild abdominal tenderness to palpation. The remainder of the examination is unremarkable. So notable findings on this exam is that the patient is tachycardic, tachypnic, with some mild signs of dehydration and these deep, rapid breaths, some potential mild tenderness to palpation. Laboratory results are positive for urine and serum ketones, as well as blood glucose of 360, sodium of 134, potassium of 4.5, bicarbonate of 14, chloride of 100. venous blood gas shows 7.1. So I also recommend highlighting abnormal lab values. Once you cross-check them with the reference range, I don't want you to ever look back at that table of reference range or normal values ever again. So look once, highlight the abnormal labs, and then don't waste your time looking back there again. So some students develop a system where they highlight the right side of the number if it's elevated and the left side of the number if it's low, or vice versa. You can figure out a system that works for you. But once you check that number with the reference range, I don't want you to ever waste your time looking back at that table again. So that's why highlighting the abnormal vital signs and the abnormal lab values is so crucial, because it's going to be a huge time saver if you need to look back at the stem. So let's take a stab at interpreting these labs. I think it's always really important when you get these lab values to try to synthesize the findings and try to interpret what they mean. So instead of listing all these labs over again in your head, you want to put them together and see, what are these labs trying to tell me? What is the constellation of these lab findings trying to tell me? So let's take a look at these. So the blood glucose is elevated. There are ketones present in the urine and the serum. And then we have these electrolytes, and the key findings here are that the bicarbonate is quite low and the venous blood gas is quite low. So we are in a situation here, a normal pH is about 7.4. So we are in an acidosis situation, and then we have to figure out whether it's a metabolic or a respiratory acidosis. And so we're given a bicarbonate of 14, and so that's going to be consistent with a metabolic acidosis. And based on the physical examination, we know that this is not a respiratory acidosis superimposed on a metabolic acidosis, because the respiratory rate is elevated and the patient is tachypnic. And so if the patient is tachypnic, they're going to be blowing off CO2. And so it's going to actually cause a respiratory alkalosis, because the PaCO2 is what causes a respiratory acidosis. So the respiratory rate itself tells us that this has to be a purely metabolic acidosis, because there can't be a superimposed respiratory acidosis, because the patient is tachypnic and is breathing fast, and so we'll be breathing off PaCO2. So we have a metabolic acidosis only with a pH of 7.1, and then the obvious next question is this an anion gap or a non-anion gap metabolic acidosis? So we can calculate our anion gap. I recommend always calculating the anion gap whenever you're in a metabolic acidosis situation. Don't forget to calculate that anion gap, because it's going to be a huge clue as to what's going on, right? Because there's a very specific differential for anion gap versus non-anion gap. And so that's really going to help you narrow down what's going on here. So even if you already have a sense what's going on, I would still recommend it. So here, to calculate it, we're going to do sodium 134 minus bicarbonate minus chloride. Okay, so that's going to be an anion gap of 134 minus 114, so that's 20. So this is elevated, and this is going to be an anion gap metabolic acidosis. And remembering our mud piles mnemonic for the causes of anion gap metabolic acidosis, we're essentially given the answer here in the question stem. We're told that there are urine and serum ketones, and so ketones are going to be a cause of anion gap metabolic acidosis. And specifically in this situation, let's synthesize all these findings. So we have a young patient presenting with abdominal pain, nausea, vomiting in the setting of a few weeks of increased appetite, so polyphagia, increased thirst, polydipsia, with a family history of autoimmune disease, presenting with some signs of dehydration on exam, deep labored rapid breathing, and an anion gap metabolic acidosis. So put together, this is most consistent with DKA, and we're told that there are ketones in the urine and serum. So this is diagnostic in the setting of this elevated blood glucose, about 360. So all these findings put together are consistent with a presentation of DKA. So the family history of autoimmune disease was important here. We'll talk about that in a bit, as well as these rapid, deep breaths. So you may remember that what these are called. Do you remember? They're called Kussmaul breaths. And so these rapid, deep, very deep respirations are small breaths that are seen in DKA, and they correspond to the patient's compensatory mechanism, right? We have an anion gap metabolic acidosis, so the patient wants to compensate for that acidosis by blowing off additional PaCO2, and so the tachypnea is a way for the body to get rid of some excess acid, and so that's going to be a compensation to the underlying metabolic disturbance. So taking a look at our answer choices, we're seeing that these are all a combination of insulin, some form of fluid, and something else in our fluid. So this is a tricky question, and you have to know a lot about the details of DKA management. So let's actually take a moment to review some of the key elements of DKA and its management, and then we'll come back and look at these answer choices and try to work through them. So DKA is most commonly seen in type 1 diabetes, and it's often seen in conjunction with either a personal or a family history of autoimmune disease. Remember, type 1 diabetes is autoimmune, and so this patient did have a pretty strong family history of autoimmune disease. The presentation is going to be a preceding history of the classic signs of diabetes mellitus, so polydipsia, polyphagia, and polyuria. Here we were told about polyphagia and polydipsia. We weren't specifically told about the polyuria, but given the signs, the mild signs of dehydration, we can assume that this patient was having some polyuria. And this is really one of the key findings. These patients present with a large diaeresis, and that's how a lot of their electrolytes get abnormal, is because they're diuresing out a lot of their electrolytes. So it presents acutely with abdominal pain, nausea, and vomiting. These small breaths that we discussed already, and these are a compensation for the metabolic acidosis. So they're a respiratory compensation for the metabolic acidosis. Often we'll see signs of dehydration because of this diuresis. And patients may have altered mental status, but they might not. So this patient didn't, but if you're seeing altered mental status with a similar presentation, that's definitely consistent with DKA. And we can see this triggered by an infection or some sort of stressor or illness, not always. So if you don't see it, that's okay. It can still be DKA, but if you do see it, that's an additional clue. And this patient did have a cold and was feeling under the weather, as we were told. So likely this triggered her DKA. And remember that you can have an initial presentation of DKA, even if the patient doesn't have a personal history of type 1 diabetes. So you might see questions where the patient has not yet been diagnosed with type 1 and is presenting for the first time in DKA. And that's actually a very common way for patients to present for type 1 diabetes, is rather than presenting with findings on lab values that are consistent with diabetes, they might actually have their initial presentation be in type 1 diabetes. And so don't be surprised if you see this presentation, even if the patient has no past medical history. In terms of diagnosis, the serum glucose is typically in the 300 to 500 range. So it doesn't have to be that high. This is elevated, but it's not as high as you would see in HHS, for example. The bicarbonate is going to be less than 18, right? So we're going to see evidence of a metabolic acidosis. And classically, it's going to be an anion gap acidosis, right? So this is the D in your mud piles. The D is for DKA. You'll have the presence of serum ketones and urine ketones. So for example, beta-hydroxybutyrate is a ketone. So if you don't see the word ketone, you should be able to recognize the names of the ketones. For example, beta-hydroxybutyrate. And these ketones, as a reminder, come from fatty acid breakdown in the liver. So you might see a pathophysiology question about these ketones. So this is important to remember. Fatty acid breakdown in the liver cause or release the ketones. Now, this is a really key point especially for management. So in these patients, the serum potassium might be normal or might actually be elevated, but they have a total body potassium deficit. So this is one of the highest yield points of this question and gets tested all the time on boards questions. So the serum K appears elevated. So why does the serum K appears elevated? Remember that potassium and protons shift in and out of cells. So because there are so many protons around, because of the metabolic acidosis, these excess protons are going to shift into the cell, and the potassium ions are going to shift out of the cell. So protons shift in, potassium shifts out, And so remember that when we measure potassium in the serum, it's a measure of the extracellular potassium, not the intracellular potassium. So the extracellular potassium appears elevated because of the shifting, the cell shifting with the protons, right? Protons in, potassium out. Now, remember that these patients also have a large diuresis occurring. That's one of the characteristic features of DKA. So because of this diuresis, their total body potassium is actually decreased because they're peeing out all their potassium because of the diuresis. But what we're measuring in the serum is falsely elevated because of these cell shifting. And then once you start insulin, remember insulin actually drives potassium back into the cells, right? Our management of hyperkalemia, remember C big K, the I stands for insulin. So insulin is going to drive your potassium back into the cells, which is going to lower your serum potassium. And the combination of this plus the diuresis can actually lead to dangerously low hypokalemia. So potassium management is going to be a crucial aspect of DKA management. So you want to pay attention to the potassium in DKA questions. All right, so that wraps up our discussion of presentation and diagnosis. Now let's talk about management. So management is going to be a combination of insulin, fluids, and then electrolyte management. So first, for fluids, it's going to be crucial to start rapid infusion of isotonic fluids. So the preferred fluid for DKA is going to be normal saline, so 0.9%, just regular normal saline. And this is important that we're using an isotonic fluid. And you don't add D5 or dextrose 5% or D5, you don't add that to the normal saline until the glucose is less than 200. Okay, so until we have brought down that glucose significantly with our insulin, we're not going to add dextrose to the fluids. Now, it's important to add it eventually because we don't want to cause hypoglycemia, which would also be very dangerous. And in these patients who are going to be on continuous insulin infusions, they do run the risk of becoming hypoglycemic. So you watch that sugar closely. Once it gets below 200, you add in D5 to your normal saline. Insulin, you're always going to start with continuous IV infusion, okay? So this is not the time to be measuring, counting carbs and specifying how many units are going to give at each time of the day. We want these patients on a continuous IV insulin infusion because this allows us to have the most accurate titration, and we don't have to worry about waiting several hours before giving them their next dose. Now, the caveat is that you don't want to give insulin if their serum potassium is 3.3, because remember, insulin is going to further drive the potassium into the cells. And so we could get an even lower potassium, and that would be really dangerous, right? We can get arrhythmias, and those can progress to very dangerous arrhythmias. So if the potassium is already low, right, we would expect it to be high in the serum because of the cell shifting. But if it's already low, less than 3.3, which is really lower end, very lower end of normal, we're actually not going to go ahead and give insulin because of the risk of dangerously low hypokalemia. So you're then going to transition to basal bolus subcutaneous insulin once you meet a few criteria. So the patient has to be able to eat, right? They have to be able to tolerate food, no longer vomiting, no longer nauseous. Their glucose has to be less than 200. The anion gap must be closed, and the bicarbonate must be above 15 or greater than equal to 15. So our acidosis is resolving, okay? So this is really important. Start with continuous insulin and then transition to basal bolus sub-Q once we meet these criteria. Okay, so what we're gonna start with, isotonic normal saline, continuous IV infusion of insulin, and then for the potassium, we're going to add IV potassium into our fluids if the potassium is less than 5.3. If it's above 5.3, it's already high enough. We don't have to worry about that, but oftentimes it won't be because remember that these patients are diuresing out their potassium. So our fluids, we're going to add IV potassium into the fluids if it's less than 5.3. And then bicarbonate, we really would only consider this if the pH was really low, less than or equal to 6.9. This patient's pH was a bit higher, and again, this is not you must do, this is a consider. So I don't think I've seen a lot of questions, if any, testing this concept, right, of the bicarbonate. I think it's important to think about that if the patient is so acidotic that we may need to give some bicarbonate, but in most cases, you don't need to. And then finally, you might get questions about which of these markers is best to track in terms of resolution. And so, in terms of the the best marker of resolution, it's going to be the anion gap. So you're going to follow that anion gap, and once that anion gap closes, that's kind of when we transition to the next stage of management. So if there's a question about what is the best marker of resolution, or what should you follow the most closely to see how the patient is improving or progressing, those types of questions, it's going to be the anion gap. You can also watch the ketone levels, so beta hydroxybutyrate, but anion gap is often going to be the best answer here. I doubt they would have you pick between these two because they can both be correct, but most of these questions are going to be having anion gap as the correct answer. So anion gap is your best marker of resolution. Okay, so now that we know how to manage DKA, let's take a look at these answer choices again. So first, right off the bat, A, B, and C, right? These three, basal, bolus, SQ. So we know right off the bat that we have not reached the parameters required to transition to subcutaneous insulin, right? We needed the anion gap to be closed. Here, our anion gap is still 20. We need the sugar to be less than 200. Our sugar is 360. We need our bicarbonate to be greater or equal to 15. It's 14. So, and the patient needs to be able to eat, and here she's having nausea and vomiting. So we have not met the criteria to transition to basal bolus subcutaneous insulin. So we must choose continuous IV insulin. So right off the bat, we can get rid of A, B, and C. So then D through F are all options with continuous IV insulin. And so then we look at the next step. So then we're given the choice of half normal saline or full normal saline. Okay, so we are not sure yet which of these other options we're going to need, but we do know that we need normal saline. We need isotonic fluids. So E can be the only correct answer, right? Because we don't want half normal saline. We know that we need isotonic fluids. And then just looking at the other answer choices. So bicarbonate would only be appropriate if the pH was less than or equal to 6.9. So this doesn't fit, right? And then we know that D5 we would only add if glucose was greater than or equal to 200. So we also don't meet those criteria. So we're able to identify the correct management. So the first step in management of DKA is going to be continuous IV insulin with normal saline, isotonic normal saline, and IV potassium. So we've identified the correct answer here, which is E. So there's a lot of details that you do need to know about the management of DKA. And so I would make sure that you understand the presentation and be able to identify all the features in the stem that were consistent with the presentation, and that you're able to identify the key findings that we discussed. And then finally, in terms of management, that you understand these core principles that we discussed. So that wraps up our question of the week, and thanks so much for listening.